everyone, my name is Erin Weethorn and I'm an internal medicine clinical pharmacy specialist at IU Health Methodist Hospital. I work on our renal and metabolic disorders floor, so as you'll see in my coming lectures, they align pretty well with my practice area. Today is my first of 3 lectures and we'll be discussing diabetes mellitus. Our objectives for today's lecture are to discuss glycemic targets for diabetes, to design an insulin regimen for type 1 diabetes, to determine a treatment regimen for type 2 diabetes, to explain different diabetes goals and treatments in special populations, to summarize hypoglycemia management principles, and finally, to establish a treatment plan for hyperglycemic emergencies. Before we dive into our glycemic targets and our treatment plans, I do think it's important for us to realize when we start to diagnose patients with diabetes in order to appropriately treat their new disease state. We can do this with a few different laboratory values, the first of those being the fasting plasma glucose. This is when a patient has no caloric intake for 8 hours or more, and they're diagnosed with diabetes when they have a blood glucose reading of greater than or equal to 126 milligrams per deciliter at this time. We can also use the 2-hour prandial glucose during an oral glucose tolerance test, and this is a reading of greater than 200 milligrams per deciliter. What I've seen in some providers' offices is that a patient will come in and they'll be fasting, will get a fasting plasma glucose, administer an oral glucose tolerance test, and have them stick around for 2 hours in order to get that 2-hour prandial glucose in order to have 2 definitive lab values for the diagnosis of diabetes if we're suspicious or it's a patient that previously had prediabetes and may now be diagnosed with diabetes. The A1C value is the laboratory value that I most often look at in patients with diabetes because this is a management of blood glucose values over the last 3 months. And our diagnosis for diabetes is greater than or equal to 6.5%. I did mention prediabetes before, and in comparison, this A1C value for prediabetes is 5.7 to 6.4%. We can also diagnose somebody with diabetes if they come in with symptoms of hyperglycemia or hyperglycemic crisis and just draw random glucose at any time and it is greater than or equal to 200 milligrams per deciliter. It's also important for us to understand the differences between type 1 and type 2 diabetes because we will treat these patients differently. Type 1 diabetics are those with the autoimmune beta cell destruction that leads to absolute insulin insufficiency. And due to this absolute insulin insufficiency, they will require insulin therapy as part of their diabetes treatment. Our type 2 diabetics have a progressive loss of adequate beta cell insulin secretion that may or may not be associated with obesity and often leads to insulin resistance. Patients may require insulin as part of their treatment plan when they're type 2 diabetic, but it's certainly not required. Now let's start to discuss our glycemic targets. Again, I utilize the A1C value quite often, but we will use all 3 of these values in order to establish patients on regimens and then to alter their regimens as we get more readings. The A1C goal for most non-pregnant adults is less than 7% without significant hypoglycemia. You can use provider judgment and patient preference to target lower A1C goals, just as long as you're avoiding those hypoglycemia and other adverse effects with treatment. It may be beneficial for your patients to do so and push A1C values of maybe 6.5%, 6%, etc., because this has been shown to decrease rates of those microvascular complications of diabetes, such as retinopathy, neuropathy, and diabetic kidney disease, as well as lower the risk of cardiovascular disease death and cardiovascular disease rates long term. We also use the preprandial plasma glucose or our fasting plasma glucose at a target of 80 to 130 milligrams per deciliter for diabetic patients, and our peak postprandial plasma glucose target is less than 180 milligrams per deciliter. I do like to show this table just so that we understand exactly what that A1C rating correlates to with blood glucose values. Throughout this presentation, I will most often utilize milligrams per deciliter when talking about blood glucose readings because that is the values in which my EHR system reports. However, you may be in a place where you utilize millimoles per liter, so I thought it was fair to display those as well. So when we're looking specifically at our A1C goal of less than 7%, this correlates to an average blood glucose reading over that 3-month period of less than 154 milligrams per deciliter, which I think should be attainable for many patients overall. I also really like this graphic that's within our American Diabetes Association Standards of Care for Diabetes Management in 2022 because it shows how we can individualize glycemic targets to meet our patient-specific needs. Some of the factors that we can individualize based on are modifiable, while some are not so modifiable. So for example, a patient that has a new diagnosis of diabetes, likely going to live quite a longer time with minimum comorbidities, we might target a more stringent A1C goal than our 7%, so maybe less than 6.5% for this patient. However, a patient that already has end-stage renal disease, they have a very short life expectancy, and possibly they have had diabetes for a long time, this is when we might be a little bit less stringent and target an A1C of up to 8%. I also thought it was important to discuss continuous glucose monitoring. While this is not something that necessarily all patients have right now, I do think that it's going to become more and more common and will be considered the standard of care in patients, especially with type 1 diabetes. In order to utilize these ratings, it's first important to make sure that the patient captures data for at least 14 days and that the continuous glucose monitoring device is active for 70% of that time. The time in range is the value that we will often look at as our base. So most patients will start with a goal of 70 to 100 milligrams per deciliter. However, with your patient, you can make a patient-specific goal that could potentially allow for maybe a higher low end of the goal. So if they feel hypoglycemic at 75, we would want to go ahead and move that up to maybe 80 to 180 or 90 to 180 for that specific patient. However, the important thing is we want to target a time in range of greater than 70% with our patient. I also wanted to point out when you're looking at this table that we allow more patients to have a higher amount of time above range than we do a time below range. So our time above range should be less than 25%, while our time below range should be less than 4%. And this is because we do see quite high risk with hypoglycemia in our patient population. There is published data suggests that a strong correlation between the time in range and A1C values exists, so that's why we're able to use this time within range. And then finally, when we have some targets and we started something on our regimen, we need to realize how often we should monitor their A1C in order to see if we're achieving our goals. So for patients that are at their A1C target, say their A1C is 6.8%, we're happy with that, we may allow patients to have their A1C monitored 2 times per year just to make sure that they're staying within that range. However, patients whose therapy has recently been changed and are not meeting their glycemic goals will likely see them within 3 months to get a new A1C value to reflect the change over that 3-month period. So we'll end up getting lab values at least quarterly in these patients. Now we'll start to discuss type 1 diabetes treatment. And just to remind you that hallmark of type 1 diabetes is absent or near absent beta cell function, so insulin treatment is essential for these individuals. Quickly, I wanted to go over our insulin kinetics because we will be talking about all of these insulin therapies and how to utilize them for specific patients. Our ultra short-acting insulins are aspart, lispro, and glulisine. We can anticipate an onset of within 15 to 30 minutes, and a peak at 1 to 2 hours. The duration is quite short, so it should wear off between 4 and 5 hours. Our short-acting insulin is regular insulin. We'll see it onset a tiny bit later at 30 to 60 minutes and a peak at 2 to 3 hours, and a duration of 4 to 6 hours. Our intermediate acting insulin is NPH. Its onset is within 2 to 4 hours and a peak at 4 to 8 hours. Its duration is 8 to 12 hours, so you'll often see NPH dosed either 3 times a day or twice a day. I personally prefer twice daily NPH regimens just to relieve at least a stick for a patient. Long-acting insulins are glargine and detamere. Their kinetics are slightly different, so glargine will have an onset at 4 to 5 hours and a duration of 22 to 24 hours, while detamere will have an onset within 2 hours and a duration that's quite variable at 14 to 24 hours. It is known that lower doses of detamere do have a shorter duration, so that's something to keep in mind for these patients. We really don't expect our long-acting insulins to have a peak due to their kinetic values. They should provide a pretty steady rate of coverage throughout the day. Most long-acting insulins are dosed daily or sometimes twice a day. And then our ultra-long-acting insulin is degludec, with an onset of about 2 hours and a quite long duration of about 40 hours, and again, no peak value. However, degludec is most often dosed just once a day. If not specifically stated when you're ordering an insulin product, it's often assumed to be 100 units per milliliter. However, we do have long-acting and short-acting concentrated insulins that can be considered when patients approach a insulin requirement of about 250 units per day or more. Our long-acting concentrated insulins are degludec, which is U200 or Tresiba, so that U200 stands for 200 units per milliliter rather than the 100 units per milliliter. Glargine comes in U300, Toujeo or Toujeo Max at 300 units per milliliter, and regular U500 is Humulin R at 500 units per milliliter. Now, I just told you on the previous slide that regular insulin is a short-acting insulin. However, when you give it in this concentrated formulation, it does have a delayed onset and longer duration of action. So the characteristics are a lot more like our NPH intermediate acting insulin than rapid acting insulin. So that's why in the concentrated formulation, we do consider it a long-acting insulin product. The good thing about U500 insulin is because it has rapid-acting properties, it will function as both basal and bolus insulin, while U200 and U300 insulins will still require some mealtime coverage. We also have one short-acting concentrated insulin product, which is Lispro at U200 or Humalog, and this is a 200 units per milliliter product. We also have combination insulin products, so NPH 70% and regular 30% is the one that I see most common in Humulin 70/30 or Novolin 70/30. So for example, if you were to prescribe your patient NPH and regular 70/30 or Humulin 70/30 at 10 units, they would effectively be administering themselves 7 units of NPH with 3 units of regular insulin. Often because you're administering both an intermediate acting insulin and a short acting insulin at one time, this will require only 2 injections per day, often given prior to breakfast and prior to dinner, as compared to the other regimens in which we'll talk about, which will require likely 4 or more injections per day when we're talking about our bolus coverage as well as our basal coverage. Our Lispro mixtures are protamine-based Lispro 75% and plain Lispro 25%, or Humalog 75-25, and then just at different percentages, protamine-based Lispro 50% and plain Lispro 50%, or Humalog 50-50. And then we also have degludec 70%, aspart 30%, which is Ryzodeg 70/30. Probably one of the most common questions that I get asked from both providers and patients is how to store the insulin products, and I left my insulin out of the fridge for X amount of time. Is that okay? So you should counsel your patients that they should refrigerate their insulin vials and pens that aren't in use. However, we should not tell them to freeze the product. This will degrade the product and make it not able to be used. If opened, most vials and pens do need to be used within 28 days, even if they are refrigerated. Most insulin products are stable for quite a bit of time outside of the refrigerator at room temperature. Of course, we don't want to leave them in like a very warm car, but at room temperature, sitting within the house in an appropriate place could be longer. So vials, this is typically a 28-day period at room temperature, with the exception of Detamir that can be used for within 42 days, so longer time. Pre-filled syringes are actually quite variable, so this is something that I take on a case-by-case product-specific basis, and you can look in the package insert to find this information, or on Lexicomp or within your favorite resource, but they can be anywhere from 10 to 28 days. So if your patient is concerned that they left their pre-filled syringe out for 6 hours for whatever reason, it is typically okay to use as long as nothing happened to the pre-filled syringe when it was sitting out. It's also important to counsel your patients on appropriate insulin delivery. So we use subcutaneous administration for maintenance dosing. This will lead to slower absorption than intravenous or intramuscular. However, it is easier for patients to administer subcutaneously, as well as more predictable pharmacokinetics for them in this instance. They can inject into the abdomen, thigh, buttock, or upper arm. The stomach does offer the fastest absorption, and I think that most patients do prefer using their stomach as well, just because they can see the injection pretty well as they're giving it to themselves. Patients that sometimes I believe don't like injecting into their abdomen are pregnant patients, so it is important to let them know that they can inject into other areas. It's also important to have your patients rotate sites of injection to prevent lipohypertrophy. Now we talked all about insulin products, so how do you decide what dose and what insulin products to use? So this is what we're going to start talking about now. Typically, especially in an insulin naive patient, we'll start a weight-based basal bolus insulin regimen. The total daily dose that's typical for type 1 diabetics is 0.4 to 1 units per kilogram per day, and the American Diabetes Association does recommend titrating to a goal of about 0.5 units per kilogram per day within the starting regimen. However, newly diagnosed patients typically have a kind of like a honeymoon phase when they're still naive to insulin, and require only about 0.1 to 0.4 units per kilogram per day. So we might start a little bit lower and then titrate to reach certain glycemic targets. Once we get that total daily dose based on their weight, we'll split it into 50% basal insulin and 50% bolus insulin. Our basal insulins are those longer acting insulins or intermediate acting insulins, so you can use chlorogene, Detamir, or degludec 1 or 2 times per day, or NPH 2 or more times per day. A lot of times the choice of insulin product to me depends on patient-specific factors. If they want to try one that is only going to give them 1 injection per day of basal rather than 2, certainly a longer acting product might be better. But I also leave it a lot of times up to insurance formulary and whatever may be covered cheapest for patients. We'll also have that 50% of the bolus insulin, which will be our short-acting insulins, Lispro, Aspart, Glulicine, or Regular, before each meal of the day. Patients should be instructed to check their blood glucose at least 4 times daily, so once before every meal and at bedtime. And some patients may also require a 3 a.m. check, especially if they're at risk for hypoglycemia. Now, we'll start off with an even 50-50 percentages for our basal and bolus insulin dosing. However, as we start to get blood glucose readings on these regimens, these percentages will often be skewed in one way or another, so a patient might end up on 60% basal insulin and about 40% bolus, and that's pretty normal for patients. example, we have this 20-year-old newly diagnosed type 1 diabetic. A lot of type 1 diabetics are diagnosed in childhood. However, I work with an adult patient population, so that's what I'm more comfortable dealing with and what I'll use as my examples. And we're going to initiate her on insulin therapy, and we found out that her insurance really likes to cover insulin glargine and insulin aspart, so those are the insulins that we're going to utilize for her. She weighs 60 kilograms, so in order to calculate a total daily dose in order to start with, we're going to take 0.2 units, which is just a little bit more than the 0.1 units lowest starting dose, units per kilogram per day, times her weight of 60 kilograms. So we're going to give her a total daily dose of 12 units based on the multiplication there. Then we're going to split that in half and do insulin glargine, which will be her basal insulin, multiplied by 0.5 or 50% of 12 units gives us 6 units. So we're going to start her off on just one daily basal injection. So we're going to instruct her to either give 6 units once daily in the morning or at bedtime. And this might be something that your patient decides with you as far as the timing of the day that works best for them. Insulin aspart is going to be our bolus insulin, so we'll again take 0.5 or 50% of the 12 units to get 6 units of bolus insulin. However, then we need to divide it by the 3 meals that the patient eats per day, so she'll get 2 units with each meal. So 2 units before breakfast, lunch, and dinner will be her regimen of the aspart. We can further individualize our insulin regimens through the insulin sensitivity factor, or ISF, and the insulin to carbohydrate ratio, or ICR. Our insulin sensitivity factor, ISF, is a measurement of how much 1 unit of short-acting insulin is expected to lower blood glucose. This is typically added to prandial insulin for premeal hyperglycemia. We can do this certainly by administering 1 unit of short-acting insulin, taking a blood glucose before the administration, and then a blood glucose 1 to 2 hours after. But that's quite tedious for patients. So often we do not do this. Rather, we can use the 1800 rule. And essentially, in the 1800 rule, you just take 1800 and divide that by the total daily dose of insulin. So for our previous patient, she was getting 12 units per day of her total daily dose. We would take 1800 divided by 12 units. The example that I have listed here is that a patient uses 36 units of insulin per day as her total daily dose. So that's adding up the basal and the bolus insulin together. When we take 1800 and divide it by 36, we get 50. So we would anticipate that 1 unit of short-acting insulin in this patient will decrease their blood glucose by about 50 milligrams per deciliter. Often how we utilize the ISF is to make a patient-specific sliding scale based on the ISF value. So for this patient, an appropriate sliding scale would be if they had a blood glucose reading between 150 to 200, they would administer 1 unit of insulin. So say that her blood glucose reading was 175, she gives herself 1 unit of insulin, which would be anticipated to bring it down to 125. You can go through specific examples with the rest of the sliding scale shown as well. I do want to point out that while we have a value of greater than 350 blood glucose reading, we would tell our patient to give themselves 5 units. Often this also requires a call to the doctor because if a patient has a blood glucose reading of 380, especially on more than one occasion, we might have them come into the hospital and just seek a higher level of care for a potential hyperglycemic emergency. I do want to point out to you that the higher the ISF, the smaller the amount of insulin that is given. So the higher number means that a patient is more sensitive to insulin. The insulin to carbohydrate ratio, or ICR, is another way in which we can individualize insulin therapy. So this is how much insulin is expected to cover an amount of carbohydrates in a meal or snack. There are average values that are shown on the screen. So adults, we anticipate that 1 unit of insulin will cover 10 to 15 grams of carbohydrates, while in children, 1 unit of insulin should cover 20 to 30 grams of carbohydrates. There are also 2 different methods in which you can calculate an ICR for your patient specifically. The first of these being that you would assess the amount of carbohydrates that the patient eats daily over 3 days, and then establish the amount of carbohydrates for each meal. The patient would divide the number of grams of carbohydrates per meal by the amount of bolus insulin that was given. So say they had 60 grams of carbohydrates and they gave themselves six units, that would be a 1-to-10 ratio. And then when they're utilizing this method, they will be checking a pre- and post-meal insulin just to make sure this is effective until you can establish an insulin to carbohydrate ratio specifically for the patient. The other method, and the one that I tend to use more often, is the 1800 rule again. So we already did the calculation to determine the ISF through the 1800 rule, and then we will divide the ISF by 3 for the number of grams of carbohydrates for 1 unit of insulin. So for our previous example, we calculated an insulin sensitivity factor, 50. So if we divide that by 50 divided by 3, we would get 17. So rather than not being super complex and saying 17, I would probably instruct this patient to give themselves 1 unit of insulin for every 15 grams of carbohydrates that they consume with each meal. And then the patients can adjust their insulin based on the amount of carbohydrates in that particular meal. So often the ISF and the insulin to carbohydrate ratio are used together. So they might take their blood glucose before a meal, and it is 200, and based on their sliding scale, they need to give themselves 1 unit as their ISF coverage, and potentially they'd be eating, I don't know, a 30 grams of carbohydrates meal. Then they would give themselves 3 total units of insulin, 2 to cover their carbs and 1 because of their ISF. Again, the higher the carbohydrate ratio, the smaller the amount of insulin that will be needed to cover each carb, which is similar to the ISF value. I did want to take a minute to just discuss insulin pumps. There's certainly a wide variety of pumps, and there's no consensus to guide the choice of injection or pump therapy in any given individual. However, this choice should be based on patient preferences, cost, the insulin type and regimen, and whether that's compatible with a pump, as well as the self-management capabilities, whether that be easier for a patient to administer subcutaneous insulin through injections or through a pump. Like I said, there's multiple different types of pumps, one of them being the hybrid closed loop pump, or the automated insulin delivery systems. These are systems, and actually the picture in the top right corner shows a hybrid closed loop pump, in which the patient wears a continuous glucose monitor, and this feeds back to the insulin pump and tells the insulin pump to adjust that basal rate of insulin based on their current blood glucose value. So for when the patient is a little bit hyperglycemic, that rate of insulin will increase, and when they may be a little bit hypoglycemic, they could suspend their insulin administration or potentially just decrease the rate. Another type of insulin pump is the sensor augmented pump system. This is when the patient will wear a sensor all the time, and they may get push notifications to a device like the one that the lady is holding in the bottom picture, or potentially in the pump itself, alerting them that they may be out of their values, and they manually change the pump settings. And then finally is the low glucose suspend, in which the insulin pump can automatically suspend or manually suspend in the cases of low blood glucose values. Typically, this will be split in between basal and bolus delivery, just like our subcutaneous injections. So our basal delivery, rather than using long-acting insulins, however, we'll use ultra-short or short-acting insulins because it will be running as a continuous infusion. And this will make up 40 to 60% of the total daily dose for a patient. The mealtime and correction will also use ultra-short or short-acting insulins, and often it's the same type of insulin that's contained within the pump. And patients will bolus based on an insulin to carbohydrate ratio and or the ISF and target glucose values. Now, we started our patient on insulin therapy, but we also need to know how to adjust insulin regimens once they are started. So it's important when you're interpreting these values that you're first ensuring that patients are taking their blood glucoses at appropriate times. Fasting blood glucose isn't a fasting blood glucose if the patient eats 30 minutes before, etc. So for the fasting glucose, we think this is related to the long-acting dose or intermediate evening-acting dose if they're giving themselves a twice or 3 times daily NPH. So if your fasting blood glucose is too low, you may want to decrease that long-acting daily dose or intermediate dose. If it's too high, you'll do the reverse and you'll increase your dose at those times. The pre-lunch glucose is a reflection of the short-acting morning insulin bolus dose, so that is what you would adjust in order to correct the pre-lunch glucose. The pre-dinner glucose could either be the short-acting lunch bolus or the morning intermediate or long-acting dose. A lot of times I will interview the patients, see what they're eating for lunch in order to determine if it would be appropriate to adjust that lunch bolus, but I often start with the lunch bolus and then adjust the intermediate or long-acting dose if we still can't correct it with adjusting the lunch bolus. And then finally, the bedtime glucose will be a reflection of the short-acting dinner bolus dose, and that is the insulin dose that you would adjust in order to better control the bedtime glucose. Again, you either want to lower it or if you want to increase it because the patient is hypoglycemic. Now we spent the bulk of our type 1 diabetes talk discussing our insulin injections that are given subcutaneously. However, there is a different insulin product, which is our human inhaled insulin, or Afrezza. This is an ultra-rapid acting insulin that has a rapid peak and shortened duration of action. However, in clinical trials, it has shown to have less hypoglycemia and weight gain than our subcutaneous formulations. The adverse effects, which are not super surprising to me, is a black box warning for acute bronchospasm in patients with chronic lung disease, so thinking of our COPD asthma patients. And there's actually a REMS, or risk evaluation mitigation strategy, for providers, patients, and the pharmacy to complete for those bronchospasms. The dosing for the inhaled human insulin product is 4 units with each meal in an insulin naive patient, which is a blue cartridge, just one of them with each meal. And then patients previously on subcutaneous insulin would convert their mealtime insulin doses to the correct dose of Afrezza based on the cartridges shown. So just to reiterate, the blue cartridge contains 4 units, the green cartridge contains 8 units, and the yellow cartridge contains 12 units. And the patient, depending on their doses, may need to give themselves 1 or 2 cartridges in order to appropriately treat their blood glucose values. Pramlintide, or Simlin, is the only non-insulin agent that is approved for type 1 diabetes. It's a synthetic analog of human amylin, which prolongs gastric emptying time, reduces postprandial glucagon secretion, and reduces caloric intake through appetite suppression. It's important to note that while this formulation is also subcutaneous, you cannot mix it in the same pen with other insulins, as that will denature the product. Adverse effects include a black box warning for severe hypoglycemia with insulin therapy and nausea. We start pramlintide at 15 micrograms subcutaneously immediately prior to meals. And then we can titrate in 15 microgram increments every 3 days to target a dose of 30 to 60 micrograms prior to every meal. And titrating this dose and this fashion can decrease the incidence of nausea experienced. That concludes our discussion of type 1 diabetes. So we'll continue and talk about type 2 diabetes. As I alluded to earlier, There are many different treatment options for type 2 diabetes, so it's important that we're taking a patient-centered approach and working with patients in order to pick the best therapy for their type 2 diabetes treatment. Some factors that we may consider along with the patient is their comorbidities. Specifically, the standards of care document describes how to use atherosclerotic cardiovascular disease risk, chronic kidney disease, and heart failure to determine a treatment regimen, the hypoglycemia risk that the treatment regimen may provide, the effect on body weight. A lot of these patients with type 2 diabetes are obese, so we may want to pick a regimen that will help them lose weight or certainly keep them from gaining weight. Any side effects of the therapy that the patient may experience. Unfortunately, a lot of these medications are still brand name products, so they can be quite costly. And of course, we want to be making sure that we're honoring the patient preferences for their therapy. I do want to point out this graphic. If you refer to any graphic within the standards of care or any page within it, really, I would point you in the direction of this one. While it seems extremely busy when I show it to you on the slide, over the next few minutes, we're going to walk through this graphic and teach you how to treat a type 2 diabetic based on this. So it seems complex, but it really provides you with all the information that you need. So starting at the top of the graphic, our first line therapy will depend on comorbidities and patient-centered treatment factors. However, this often includes metformin and comprehensive lifestyle. So comprehensive lifestyle management for a patient could be diet and exercise, and that's often what we think about. So diet, making sure that they're eating consistent and a low carbohydrate diet, and exercising, whether that be aerobics or weightlifting, as long as they're out and moving, they will see some improvements with their diabetes. And then metformin is the medication that we use for these individuals as first line. Metformin is our biguanide. It improves insulin sensitivity, increases tissue uptake and utilization of glucose by muscle, and decreases hepatic production of glucose. This is recommended for all patients if they can tolerate it and it's not contraindicated. Some of the contraindications to consider is an EGFR of less than 30 mils per minute per 1.73 meters squared, and that is definitely the contraindication that I run into most often with patients if it's not just general intolerance of the medication. Metformin does carry a black box warning for lactic acidosis, and this is especially important in our patients with renal insufficiency. However, the side effect that I see most often is our gastrointestinal intolerance. So in clinical trials, about 30% of patients did experience GI intolerance, and this can be anything from bloating to abdominal discomfort or diarrhea. Some ways in which we can mitigate this is to have our patients take metformin with meals, to titrate the dosage, so starting at a low dose and working our way up slowly to the maximum dose, or utilizing the extended release formulation. Also, we often monitor vitamin B12 in these patients because metformin can cause vitamin B12 deficiency. It's also important to note that metformin should be held at least 2 to 3 days prior to surgery, and this is due to the increased risk of lactic acidosis in the setting of surgery and NPO for the procedure. The initial dose of metformin is 500 milligrams twice a day with meals if using the immediate release formulation, or 850 milligrams daily for the extended release formulation. Again, we will increase this slowly by 250 to 500 milligrams daily due to those GI side effects, to a maximum dose of metformin 2,000 milligrams per day, most often given as 1,000 milligrams twice per day for the immediate release formulation, and for metformin extended release at 2,550 milligrams per day, and that can be given in a once daily product. I do have the renal dose adjustments listed on this side as well. So for an EGFR of less than 45, but still greater than that contraindicated value of 30 mils per minute per 1.73 meters squared, If the patient is not already on metformin, maybe that's a new diagnosis, we wouldn't start the medication. However, if they are already established on metformin therapy, we would reduce that by 50% of what they're already taking. And then, of course, if an eGFR drops below 30 mils per minute per 1.73 meters squared, even if the patient is already established on therapy, we would want to go ahead and stop the medication. Now, while we're starting these patients on metformin, it's also noted within the standards of care document for 2022 that we do have early combination therapy more prevalent now than in past iterations of this document. So traditionally speaking, when treating diabetes, a lot of times we would start metformin, continue it for 3 months, get an A1C value, possibly add on a second agent, use metformin plus that second agent for 3 months, get an A1C value, possibly add on a third agent, and so forth, and kind of use this stepwise approach for therapy. However, the Verify trial, which looked at vitagliptin in combination with metformin for early treatment of type 2 diabetes, showed that combination therapy is superior to sequential addition of medications for extending primary and secondary failure for patients. So we consider early combination therapy for any patient that has an A1C that's greater than or equal to 1.5% above target. So when we're thinking of our normal target goal of 7% or less, that would be an A1C of 8.5%. Also, we'll start early combination therapy for patients with chronic kidney disease, heart failure, or that atherosclerotic cardiovascular disease risk, because other medications that treat diabetes have been proven to have benefits for these disease states. It is also well known that each additional agent added to metformin lowers the A1C by about 0.7 to 1%, so we are expecting benefits for their diabetes management as well. So again, returning to our graphic, we started our first line agent of metformin. We're feeling good. The patient is buying into comprehensive lifestyle modifications. Now what do we do? So the next line of this graphic shows that we'll now consider if the patient has ASCVD risk indicators, heart failure, or chronic kidney disease. And whether they're present or absent will lead us to the right hand or left hand side of this graphic. So for the time being, we're going to talk about if our patient has comorbidities. So we're going to lean heavily on the left side of this graphic as shown by the circle at this time and walk through each individual disease state and how the therapies differ. So we'll start off by talking about type 2 diabetes and heart failure. In these patients, we want to start a sodium glucose cotransporter 2 or SGLT2 inhibitor with proven heart failure benefit. These agents are empagliflozin or Jardiance, canagliflozin or Invokana, dapagliflozin or Farxiga, and ertugliflozin or Stiglarto. It is important to note that when we're looking at the data with these agents that more than 70% of patients were taking metformin at baseline. However, there's newer data coming out for each of the disease states that we'll talk about that patients didn't have a background of diabetes too, so potentially just benefits at baseline. Our SGLT2 inhibitors benefits for heart failure are that they prevent heart failure hospitalizations compared to placebo. That's the disease state that we're talking about now. However, they also have benefits for other disease states as well, such as ASCVD risk and CKD. So for ASCVD, they reduce the composite outcome of myocardial infarction, stroke, and death from cardiovascular causes. And in chronic kidney disease, they reduce decline of our estimated glomerular filtration rate, end-stage renal disease, and death from renal or cardiovascular causes. These agents work through the inhibition of SGLT2, which leads to renal glucose excretion in the urine. Adverse effects that are experienced by patients are genitourinary infections, including our most probably severe Fournier's gangrene. Just imagine all of that glucose kind of spilling out in the urine could potentially harbor these infections. Bone fractures, especially with canagliflozin, this euglycemic DKA phenomenon in which patients may have a relatively normal glucose value but still be in DKA, and increased LDL cholesterol. Some considerations for these medications is that we do know that there's a smaller glucose lowering effect at lower eGFRs based on its mechanism of action. So while we may utilize these agents for other indications at low eGFR, we wouldn't expect that robust diabetes response for our A1C value. These should also be discontinued prior to scheduled surgery, and that's due to that increased risk of DKA. SGLT2 inhibitor dosing is shown on the screen. So these doses are started at a lower dose, and they're titrated every 4 to 12 weeks to the maximum dose as long as the patient needs it based on their blood glucose value, and it's tolerated without any side effects. I do like to point out again that these doses, especially those renal dose adjustments, are specific for type 2 diabetes, and you may see different recommendations for an eGFR cutoff for heart failure and chronic kidney disease patients. I like to show this graphic again, and you'll see stars next to every single time that an SGLT2 inhibitor is recommended for a specific patient population. So this is across the board, ASCVD indicators of high risk, heart failure, chronic kidney disease, to minimize hypoglycemia and to minimize weight gain or promote weight loss. So rarely is an SGLT2 inhibitor a wrong second-line agent for a patient. So across the board, as more and more data comes out, these are becoming pretty favorable. Next, we'll move on to type 2 diabetes and chronic kidney disease. And the guideline document and graphic provide two different breakdowns of chronic kidney disease. So first, we'll discuss type 2 diabetes and chronic kidney disease with albuminuria, which they specify as an albuminuria as 200 milligrams per gram of creatinine or more. The preferred agent for these patients is an SGLT2 inhibitor with evidence of reducing chronic kidney disease progression, and that would either be canagliflozin or Invokana or dapagliflozin and Farxiga. And when we have two different medications listed here for patients, or like on the previous heart failure slide, we have four, again, I'm often allowing insurance to dictate exactly which agent, especially when we're comparing both positive agents for that patient. If for whatever reason we can't start canagliflozin or dapagliflozin, we would want to start an SGLT2 inhibitor that showed evidence of reducing chronic kidney disease progression in cardiovascular trials. So maybe they haven't tested it in CKD specifically yet, but it has shown some benefit, and that would be empagliflozin or Jardiance. And then if an SGLT2 inhibitor is contraindicated, this might be due to a specific eGFR cutoff value, for example. We would want to utilize a glucagon-like peptide-1 receptor agonist, or GLP-1RA, with proven cardiovascular disease benefit. And these medications are dulaglutide or Trulicity, liraglutide or Victoza, or semaglutide or Ozempic. The other CKD category that they utilize is type 2 diabetics with CKD without albuminuria. So this is any patient with an eGFR of less than 60 mL per minute per 1.73 meters squared. For these patients, we would want to utilize either an SGLT2 inhibitor with proven cardiovascular disease benefit. So again, this is empagliflozin or Jardiance, or canagliflozin or Invokana, or a GLP-1 receptor agonist with proven cardiovascular disease benefit, which is dulaglutide, liraglutide, or semaglutide. As you can see on the right-hand side, if we needed to add on an additional agent, so say for our CKD with albuminuria, we were able to start an SGLT2 inhibitor that has evidence to reduce CKD progression. And we still needed coverage after our 3-month A1C check, and we need to add on a third agent. The guidelines suggest that we would add on a GLP-1 receptor agonist at this time. And then vice versa with our CKD with albuminuria, say we went the GLP-1 receptor agonist route first, we needed more benefit, we would then add our SGLT2 inhibitor as our third line agent. The GLP-1 receptor agonists, or GLP-1 RAs, are dulaglutide, Trulicity, liraglutide, Victoza, and semaglutide or Ozempic. And the injectable formulation only or subcutaneous is what provides those cardiovascular benefits for patients. Those with neutral cardiovascular and CKD outcomes are exenatide or Byetta, or lixisenatide or Adlixin, and then the oral formulation of the semaglutide or Ozempic. These work by potentiating insulin secretion by stimulating the beta cell growth and inhibiting beta cell death, which inhibits glucagon secretion, delays gastric emptying, and decreases appetite for patients. One thing to note is this only leads to insulin release in the presence of elevated blood glucose, which leads to much less hypoglycemia risk for these patients, which can be beneficial for many. The benefits that are seen for those with positive cardiovascular outcomes is that it reduced the composite of myocardial infarction, stroke, and cardiovascular death. Adverse effects include a black box warning for increased risk of thyroid tumors. So somebody with a history of thyroid cancer often wouldn't be a candidate for GLP-1 receptor agonists. Nausea is by far the most common side effect that I see with this medication, and this is dose dependent. So potentially you can have somebody on a low dose GLP-1 receptor agonist and still get some benefit from it. And acute pancreatitis. This is certainly whenever I have somebody with a new pancreatitis, I look at their med list and kind of see if there's a GLP-1 receptor agonist that could be potentiating it. Mostly all of these are administered subcutaneously, so similar to an insulin injection other than the semaglutide, which is both subcutaneous and oral formulation. This table shows the subcutaneous GLP-1 receptor agonist dosing, and I did break it into those with positive cardiovascular outcomes versus the neutral cardiovascular outcomes, just to direct you a little bit more. I do want to point out that a lot of these are dosed weekly, which could be an advantage for patients that may want to decrease their daily insulin injections. However, liraglutide or Victoza is dosed daily, as well as lixisenatide is dosed daily. And the exenatide Byetta immediate release formulation is dosed twice a day. These are titrated every 40 weeks, every 4 weeks, with the exception of lixisenatide, which is increased on day 15 from 10 micrograms to 20 micrograms daily. Then the oral semaglutide dosing, we administer this 30 or more minutes prior to the first food, beverage, and other medications of the day. We start the patients on 3 milligrams once daily and titrate every 30 days to a maximum dose of 14 milligrams daily. Again, bring us back to the graphic. I started the disease states in which GLP-1 receptor agonists may be preferred for, and again, like the SGLT2 inhibitors, pretty well recommended across the board. So for those with ASCVD indicators of high risk, CKD to minimize hypoglycemia, and to minimize weight gain or promote weight loss. Then talking about our third disease state in which we consider when choosing therapy is our ASCVD risk for patients with type 2 diabetes. In these instances, we choose either an SGLT2 inhibitor with proven cardiovascular disease benefit, and just to reiterate, this is empagliflozin or canagliflozin, or a GLP-1 receptor agonist with proven cardiovascular disease benefit, which is dulaglutide, liraglutide, or semaglutide injectable formulation. So the recommendations within the graphic and within the standards of care document is to pick either or SGLT2 inhibitor or GLP-1 receptor agonist, and this might be based on patient preferences. A patient doesn't want to give themselves injection, you might choose SGLT2 inhibitors, which are oral, or potentially they want other benefits from GLP-1 receptor agonists. You might go one way or the other. So you start one, you're not receiving benefit at that 3-month A1C mark, you might add the other for your third agent. And then if the A1C is above target despite metformin as your first-line therapy, an SGLT2 inhibitor, and our GLP-1 receptor agonist, this is when we would add on a thiazolidinedione or TZD, specifically pioglitazone for these patients with ASCVD risk. So TZDs are pioglitazone or Actos, or rosiglitazone and Avandia. These bind to the peroxisome proliferator activator receptor gamma on fat and vascular cells to improve cellular response to insulin without increasing insulin secretion. They decrease insulin secretion and hepatic glucose production overall. Pioglitazone does have cardiovascular disease benefits. However, this is in the form of mostly hyperlipidemia, so they decrease the triglycerides by about 10 to 20%, increase HDL by 3 to 9 milligrams per deciliter. However, they have a neutral LDL effect. It is important to note that the DREAM study with rosiglitazone did not see these positive cardiovascular benefits. They actually saw increased incidence of myocardial infarction and cardiovascular deaths. However, there were several limitations noted within the study. Adverse effects include a black box warning for congestive heart failure for both agents and myocardial infarction, specifically for the rosiglitazone based on the DREAM study. We believe that the congestive heart failure black box warning comes mainly from the increased edema that we see with these agents. The TZDs can also cause hepatotoxicity, so it's important to check your patient's LFTs at baseline and discontinue the medication if the LFTs ever rise greater than 3 times the upper limit of normal. We see some increased incidence of bone fractures, as well as bladder cancer with pioglitazone and weight gain. Pioglitazone can also be used off-label for NASH. This is our TZD dosing, so it does differ slightly for pioglitazone and rosiglitazone. We would start pioglitazone at 15 to 30 milligrams per day and increase by 15 milligrams every 4 to 12 weeks until we hit that target maximum dose of 45 milligrams daily. Rosiglitazone, we would start at 4 milligrams per day, and this can either be in a single dose or 2 divided doses. This will be increased after 8 to 12 weeks to 8 milligrams per day in a single or 2 divided doses. We'll now return back to our graphic, and this time we're going to focus on that right-hand side of the graphic. So in this instance, we started our patient on metformin first-line agent. However, they don't have any cardiovascular or heart failure or chronic kidney disease comorbidities of concern. So now, rather than focusing on their comorbidities, we're going to focus on potentially the side effects or the burdens that diabetes management can give to patients. So first we're going to focus on hypoglycemia. This is definitely a concern for certain patient populations. So if we want to minimize a patient's risk of hypoglycemia, we're going to choose either dipeptidyl peptidase 4 or DPP4 inhibitors as the second-line therapy, GLP-1 receptor agonists, SGLT2 inhibitors, or TZDs. Dipeptidyl peptidase 4 inhibitors or DPP4 inhibitors are sitagliptin or Januvia, saxagliptin or Onglyza, alogliptin or Nicinia, linagliptin or Tradjenta. DPP4 is an enzyme that breaks down glucagon-like peptide 1 and glucose-dependent insulinotropic peptide, and by inhibiting these gut hormones, we can enhance insulin secretion in response to food. This stimulates insulin response from beta cells in a glucose-dependent manner, which is how they prevent hypoglycemia. Adverse effects of the DPP-4 inhibitors include nasopharyngitis and upper respiratory tract infections, joint pain, pancreatitis, another one that I'm looking at the med list for. Bullous pemphigoid is certainly rare, but if you can nail down a medication potential cause, it could be helpful. Heart failure, specifically with saxagliptin and alogliptin. It's important to note that these should not be used with GLP-1 receptor agonists due to the similar mechanisms of action. We really won't see any increased benefits, and we can possibly cause harm to those patients if we utilize them hand in hand. DPP-4 inhibitor dosing is shown on the screen, as well as the certain eGFR cutoffs that are of concern for these patients. Now moving on to our other consideration for patients is the concern for cost. Like I said before, most of the diabetic medications are still brand names, so they can be costly for patients. One of the good things is that metformin is generic, so it can be a little bit less expensive. And when we're considering costs and choosing a second-line agent for patients, two drug classes that we consider are sulfonylureas and TZDs. Sulfonylureas include glyburide, which is diabeto or glinase, glipizide, which is glucotrol, and glimepiride, which is amaryl. These stimulate insulin release from pancreatic beta cells and may increase binding between insulin and receptors or increase the amount of receptors for insulin to act on. Adverse effects include hypoglycemia, especially in those with renal or hepatic dysfunction and in elderly patients, as well as some hematologic side effects such as leukopenia, thrombocytopenia, and aplastic anemia. While sulfonylureas may work well initially, about 1/4 of patients will have failure within 6 to 12 weeks, and another 50% will have these medications fail within 6 to 12 months. So while their effects may be good for your patient up front, they may be futile. The sulfonylurea dosing is shown on the screen. Sulfonylureas are dosed with the first meal of every day, and after the starting dose, they'll be titrated every 1 to 4 weeks to the maximum dose or until we need the glycemic benefit for patients. Most of these agents will be dosed either once or twice daily. It is important to note that when you're using the glipizide immediate release formulation, this should be split into the twice daily dosing with daily doses greater than 15 milligrams per day in order to have adequate absorption. However, when you're using the extended release formulation of glipizide, you can always dose this just once a day. While we didn't talk about indications for starting insulin therapy yet in our type 2 diabetics, I did think this was an easy way and an important way to talk about our low-cost insulin therapies. So in my practice, what I see the lowest cost insulin products being is human regular insulin, NPH, and 70/30 NPH and regular combination. This is because these insulin products are available over the counter, so patients may not have to bill their insurance in order to get them, and especially for our low-income patients or potentially our patients without insurance, this may be easily the most cost-effective way to get insulin products for them. I usually direct my patients that need low-cost insulin products to Walmart pharmacies and do instruct them to buy them over the counter in order to provide the lowest cost available, and typically they're about $25 to $50 per vial. And right now, the cheapest brand product that contains all of these formulations is the Relion brand, which is RELION. Then finally, if your patient may be a type 2 diabetic with obesity and we want to promote weight loss or potentially minimize any weight gain, The preferred second-line agent for these patients will be GLP-1 receptor agonists with good efficacy for weight loss and SGLT2 inhibitors. The GLP-1 receptor agonists will actually allow patients to lose weight, while the SGLT2 inhibitors are more of a weight-neutral product. Again, this provides specific directions that we would add a second-line agent on. So say we got our GLP-1 receptor agonist with good efficacy for weight loss. They might be losing weight, but their A1C is still above goal. Then we would add on the SGLT2 inhibitor to that regimen for our third-line therapy. Now we'll talk about when we need to add insulin therapy for type 2 diabetics. So it's not required like in type 1 diabetics, but certainly it can be considered and is recommended for those with A1C levels greater than 10% or blood glucose levels greater than 300 milligrams per deciliter at diagnosis. However, it is noted that in most patients, we'll consider adding a GLP-1 receptor agonist prior to starting insulin therapy. Another indication for starting insulin therapy earlier is when patients are experiencing sudden or unwanted weight loss. I do feel like this is a little bit rarer in our type 2 diabetic patient population. However, insulin therapies can promote weight gain. So it could be a way to utilize our blood glucose control and side effects of insulin therapy in order to allow those patients to gain back the weight that they've lost. Overall, the approach to starting insulin in type 2 diabetics is certainly a little bit different than in type 1 diabetics. Rather than starting basal and bolus injections or basal and prandial insulin and giving 4 subcutaneous injections a day, we often just start these patients on basal insulin to start off with. And typically this is started at a lower dose of 0.1 to 0.2 units per kilogram per day. And then we can increase this by 2 units every 3 days until we reach our fasting plasma glucose target. It is important that when we are titrating up this basal insulin that we are looking for signs of over-basalization of insulin. So this is typically seen whenever the patient is requiring about 0.5 units per kilogram per day or more. If there is a high differential between their bedtime to morning glucose or the postprandial glucose differentials, or if they may be experiencing hypoglycemia due to a long-acting insulin therapy. Whenever we are experiencing over-basalization or they're requiring quite a bit of insulin therapy, that's when we'll start to add prandial insulin. In addition, it may be added if the A1C is still above target 3 months or more after we started that basal insulin therapy. Typically, prandial insulin can be started with just one meal of the day, so this is typically the largest meal or the meal with the greatest excursion in blood glucose values, and we can start at either 4 units with that meal or 10% of the total daily basal dose at that time. We can then increase by 1 to 2 units or 10 to 15% twice weekly to reach our glucose targets. And as we're adding on our prandial insulin, we don't add it on to the same meal. We'll start to spread it over the 3 meals of the day. And eventually these patients will end up on a regimen that is quite similar to patients with type 1 diabetes. It is noted that type 2 diabetes patients are often more insulin resistant, so they require highly daily doses of insulin and have lower rates of hypoglycemia than type 1 diabetics. These glucose or these insulin doses can be titrated based either on the A1C or home glucose monitoring, which is very similar to our type 1 diabetics. So when we're starting insulin, we also need to pay attention to what medications we may be stopping. So when we're starting insulin, we do want to maintain our metformin therapy and many of our therapies that may provide benefits for other disease states. So thinking of our GLP-1 receptor agonist, which may be causing weight loss in patients, which we want, or maybe helping their cardiovascular risk. Our SGLT2 inhibitors, which may be helping the heart failure or CKD, we're going to want to maintain those as long as they don't become contraindicated for any reason. However, we often do stop or wean our sulfonylureas or TZDs because of the risk of hypoglycemia when these agents are added to insulin therapy. I do want to quickly hit on the other type 2 diabetic therapies that are not necessarily recommended within the graphic, but certainly can be used, especially when we're starting to dig up third, fourth, etc. line for patients. These can be the alpha-glucosidase inhibitors, meglitinides, bile-acid sequestrant, dopamine 2 agonists, and then the amylin mimetic or pramlintide, which we discussed in the type 1 diabetes section. Starting with the alpha-glucosidase inhibitors, which are acarbose or pregose, and miglitol or glycet. These are competitive reversible inhibitors of the intestinal alpha-glucosidase, which is an enzyme that breaks down polysaccharides to glucose. This delays glucose absorption without increasing insulin secretion. Adverse effects include gastrointestinal effects, definitely most common. Flatulence was actually seen in 75% of patients in clinical trials. GI effects can also include diarrhea and abdominal pain. Rashes can be common, and these medications can cause hepatotoxicity, so we will want to monitor LFTs. Contraindications include patients with DKA or multiple cases of DKA, and then any gastrointestinal disorders. So, for example, if you have a patient with irritable bowel syndrome or Crohn's disease, possibly starting these medications could exacerbate those symptoms due to their side effects. Something that is very, very, very important to note, that is if patients that are taking alpha-glucosidase inhibitors experiencing hypoglycemia, they should be instructed to take dextrose tablets or gel for their treatment. We will talk about hypoglycemia in more detail in just a little bit. And this is because whenever patients are on these medications, they won't be able to break down the complex juices and sodas, complex sugars and juices and sodas because of the mechanism of action of this medication. This slide shows the alpha-glucosidase inhibitor dosing. So for acarbose, we will start 25 milligrams 3 times a day with the first plate of each meal, and then we'll titrate that every 4 to 8 weeks based on the postprandial glucose or A1C. The maximum dose is determined based on weight, so in patients that are less than or equal to 60 kilograms, it will be 50 milligrams 3 times a day, and then those greater than 60 kilograms will be 100 milligrams 3 times a day. Miglitol dosing is very, very similar, so starting at the same dose, we'll increase to 50 milligrams 3 times a day at 4 to 8 weeks, and then we maintain this for 3 months before you titrate up. The maximum dose for all patients for miglitol, however, will be 100 milligrams 3 times a day. The meglitinides are nataglinide or Starlix, repaglinide or Prandin, and these stimulate the release of insulin from pancreatic beta cells. They can also be called our short-acting insulin secretagogues because of their mechanism of action. Adverse effects that these patients may experience when taking this medication are upper respiratory infections and flu-like symptoms, headache, and hypoglycemia, especially in elderly patients with renal dysfunction. Meglitinides dosing is shown on the screen here. Something that I think is interesting to note is that the starting dose for repaglinide is based on the A1C value whenever you're starting the medication. So for those with an A1C of less than 8%, you would start 0.5 milligrams 3 times a day, and for those with an A1C of greater than or equal to 8%, you may start 1 to 2 milligrams 3 times a day before each meal. Both of these medications are titrated in 1-week intervals. Clostebulin, or Welchol, is a bile acid sequestrant that increases bile acid production and improved insulin sensitivity. Adverse effects that can be experienced are nausea and constipation. This medication is used for hyperlipidemia with fasting triglycerides of less than or equal to 300 milligrams per deciliter, as well as diarrhea associated with bile malabsorption. It's dosed at 3.75 milligrams per day in 1 or 2 divided doses, specifically for diabetes. Bromocriptine or cycloset is a dopamine 2 agonist which affects the circadian rhythm to improve insulin sensitivity. Adverse effects include nausea, headache, and orthostatic hypotension. Bromocriptine can also be used for Parkinson's disease, neuroleptic malignant syndrome, and hyperprolactinemia based on its mechanism of action. We start at 0.8 milligrams daily, specifically in diabetes, and we titrate at weekly intervals to a maximum daily dose of 4.8 milligrams. And then finally, I wanted to also talk about tirzepatide or Mounjaro. This medication was FDA approved for the treatment of type 2 diabetes on May 13th of this year. Because it's so new, it hasn't necessarily found its way into our standards of care document for diabetes. However, I do anticipate that it will find a place, possibly alongside our GLP-1 receptor agonist, especially for promoting weight loss, as it has been found to do that in clinical trials. This is a GLP-1 agonist in addition to a glucose-dependent insulinotropic polypeptide or GIP, which increases glucose-dependent insulin secretion, decreases appropriate glucagon secretion, and slows gastric emptying. Adverse effects include that black box warning for thyroid C-cell tumors like the GLP-1 agonists. We can see hepatotoxicity with this medication, so you would monitor LFTs. And then, of course, GI effects, diarrhea, nausea, as well as that decreased appetite, which we may or may not use to our advantage in patients that would like to lose some weight as well as need treatment for their diabetes. These are subcutaneous once-weekly injections, like many of our GLP-1 agonists. We would start at 2.5 milligrams subcutaneously once weekly and titrate in 2.5 milligram increments every 4 weeks to reach a maximum dose of 15 milligrams weekly. These graphics are based on the clinical trials that Lilly, the drug company, did in order to get this medication FDA approved. So the primary endpoint in these trials was the mean change in A1C from baseline at 40 weeks. It is important to note that all patients in these trials had type 2 diabetes and were taking metformin. But one thing I think that is really notable about these trials is rather than having placebo-controlled trials, they compared tirzepatide to Ozempic in these trials, and they actually included tirzepatide at multiple different doses in order to also promote kind of like a dose-finding trial. So if you look at the graphic on the left-hand side of the PowerPoint, you can see that tirzepatide or Mounjaro at 15 milligrams daily reduced the A1C value the most, and all doses of Mounjaro decreased the A1C value more than Ozempic, at least numerically. In the middle graphic, you can see that the A1C did drop rather quickly, so within the first 8 to 12 weeks or so with all of these medications, and that decrease was long-standing at the 40-week mark. So you can see it kind of taper off and plateau out. And you see here that patients on the 15 and 10 milligram dose of tirzepatide reached an A1C value of 6%, which I definitely need to applaud these patients because I think it is very difficult to get patients to that 6% A1C value. And then finally, the graphic on the right-hand side shows the percentage of patients that achieved our A1C goal of less than 7%. So across the board, I think these rates were relatively high, even with the Ozempic at 79%. However, again, at the 10 milligram and 15 milligram dose, we see the most benefit with 86% of patients achieving the A1C value of less than 7% overall. So I do think this data is notable, and I'm certain that we will see this utilized in patients going forward. However, just as a reminder, because this is such a new medication, certainly will be expensive for patients starting off. That concludes our type 2 diabetes management discussion. And now we will discuss diabetes management in specific special populations. So the special populations that I wanted to focus on are pregnant patients, geriatrics, and patients that are admitted to the hospital and inpatients. So starting with our patients with diabetes and pregnancy, we have seen increased rates of type 1 diabetes, type 2 diabetes, as well as gestational diabetes in pregnant patients over the recent years. It's important that these patients are counseled to optimize their treatment regimen and A1C prior to pregnancy. So actually the standards of care document do recommend that patients are put on contraception until they're ready to become pregnant. And while most patients have an A1C goal of less than 7%, our patients that are pregnant will have an A1C goal of less than 6.5%. And this more stringent goal is used to reduce the risk of congenital anomalies, preeclampsia, preterm birth, and other complications. They'll also have, once they become pregnant, will have lower glucose targets as well and more stringent. So the fasting plasma glucose will be less than 95 milligrams per deciliter. The postprandial 1 hour glucose is less than 140 milligrams per deciliter as a goal. And at 2 hours, will be less than 120 milligrams per deciliter. And then finally, the A1C goal once a patient is pregnant is less than 6%, as long as this can be achieved without increasing the risk of hypoglycemia for the patient. Gestational diabetes is a phenomenon that happens during pregnancy. So we know that children of untreated gestational diabetes are more likely to have impaired glucose tolerance in childhood. So it is important to identify these patients and start to work with them in order to treat their gestational diabetes. The first line treatment for these patients is lifestyle behavior change, and often this alone will allow patients to be treated. So this includes medical nutrition therapy that's designed with a dietitian to provide adequate caloric intake for both baby and the mother, as well as physical activity, which can be in the form of weightlifting, aerobic exercises, or both. And then we would utilize insulin if needed in order to treat the gestational diabetes if the lifestyle behavior changes is not enough for a specific patient. For those with pre-existing diabetes, we often discontinue all oral medications. We know that metformin and glyburide do cross the placenta, and unfortunately, with the other oral and non-oral injectable medications, we just lack the long-term safety data because these medications are relatively newer. We do prefer insulin for both our type 1 and type 2 diabetics because we know that no insulin products cross the placenta. Often patients with diabetes who are pregnant require higher doses during their pregnancy than their pre-pregnancy insulin requirements. And then after the patients give birth, their requirements drop dramatically after delivery. So these patients should be counseled to check their blood glucose during pregnancy pretty frequently, as well as after their delivery, in order to prevent hyperglycemia or hypoglycemia. We'll also recommend aspirin 81 to 162 milligrams daily at 12 weeks gestation for patients who are pregnant in order to prevent the risk of preeclampsia. Geriatric patients are definitely a concern, as over a quarter of people over the age of 65 have diabetes and about half have prediabetes. Additionally, a high risk of cognitive decline and institutionalization occurs in our geriatric population, which certainly adds an extra layer to their diabetes management. And glycemic control is important for many geriatric patients' recovery, wound healing, hydration, and avoidance of infection. Overall, we often consider less stringent A1C goals of less than 8% in those with multiple coexisting chronic illnesses, cognitive impairment, or functional dependence. We do emphasize medications with low risk of hypoglycemia in these patients. We'll still utilize metformin as our first line agent, and then we can reflect back on our graphic for type 2 diabetes for other medications that can be considered in patients where hypoglycemia is a risk factor. I do want to point out the diabetic medications that are on the Beers criteria. So first is the long-acting sulfonylureas, glimepiride and glyburide, and this is due to the increased risk of prolonged hypoglycemia with our long-acting sulfonylurea formulations. And then rapid-acting insulin also makes it on the Beers list due to that pretty rapid decrease in blood glucose. You can still utilize these agents in our geriatric patient population, you just have to do so with these specific risks in mind. In addition to emphasizing medications with low hypoglycemia risk, we also want to simplify any complex regimens. So if it's possible to control a type 2 diabetic on a once daily basal insulin injection, we're going to try to do so just in order to cut out that multiple daily injections for the patients. And the same can be said for oral therapy as well. If we can increase the doses of one or two medications and really consolidate, that can be helpful for these patients. And then finally, we'll talk about our hospitalized patients. So even in patients without diabetes, we often initiate insulin therapy when we have two blood glucose readings of greater than 100 milligrams per deciliter while in the hospital. Our glycemic targets are most often 140 to 180 milligrams per deciliter, and this comes from the NICE sugar trial that was done in critically ill patients, where they found higher mortality with tight glycemic control of 80 to 110 milligrams per deciliter compared to a more conservative management of 140 to 180 milligrams per deciliter. However, you may consider a more stringent goal of 110 to 140 milligrams per deciliter in select patients such as those who have went through cardiac surgery or critically ill post-surgical patients in order to promote the wound healing that's needed for them. Glucose lowering treatments may be a little bit different depending on the type of patient that you're taking care of. However, whenever they're in the hospital, this surrounds along insulin therapy. For non-critically ill patients with poor oral intake, we'll often start basal insulin with some sort of bolus correction insulin. So this may be a sliding scale or potentially a certain ICF for this specific patient. Non-critically ill patients with good oral intake can be started on a basal regimen with scheduled prandial with a correction component. So that scheduled prandial may look as a certain number of units scheduled each day with meals, or it may look like a carb ratio as we talked about earlier. And then in our critically ill patients, we often use a continuous insulin infusion on them because that is what they require. It is strongly discouraged to use sliding scale alone in patients, so especially in our patients that have diagnosed type 1 or type 2 diabetes, we need to make sure that we have some sort of basal insulin, especially with our type 1 diabetics. It would be inappropriate to manage them with only bolus injections. Oral regimens are often held upon admission, and if this isn't done, we need to remember to make sure that providers are holding metformin at the bare minimum 1 day prior to surgery and SGLT2 inhibitors 3 days prior to surgery. We can consider restarting our oral regimens about 1 to 2 days prior to discharge if we want to establish a good glucose regimen for them that may or may not include insulin prior to their discharge. However, many hospital formularies prevent us from doing so due to the certain risks that these medications might have. And then finally, every single hospital system that I've either trained in or practiced in does have some sort of hypoglycemia management protocol. that's required to utilize whenever any sort of insulin is ordered for a patient. So I definitely recommend this so that the nurses can appropriately take care of patients without having to reach out to the provider if a patient were to become hypoglycemia, and that's certainly safer for the patients as well. Now we'll specifically talk about our hypoglycemia management. Hypoglycemia can happen for a multitude of reasons. So potentially, we as providers increase the insulin dosage, or the patient increase their insulin dose because maybe they felt hyperglycemic and then they cause themselves to be hypoglycemic. If a patient is feeling crummy and they're not eating a lot, but they're giving themselves the same amount of insulin that they normally would take, that could cause hypoglycemia. And then in the cases of increased exercise or muscle utilization, they may be utilizing their glucose that's stored in their body more effectively, or in the case of excessive alcohol intake. Symptoms of hypoglycemia are displayed on the screen. These can be shakiness and tremors, irritability and agitation, confusion, slurred speech, blurred vision, drowsiness and weakness, and hunger. We do utilize less than 70 milligrams per deciliter as the threshold for hypoglycemia, and this is because that's when their neuroendocrine response to hypoglycemia will start. There are certain definitions of the grades of hypoglycemia, with level 1 being the least severe and level 3 being the most severe. So level 1 hypoglycemia is when there's a blood glucose reading between 54 milligrams per deciliter to less than 70 milligrams per deciliter. Level 2 hypoglycemia occurs when the blood glucose is less than 54 milligrams per deciliter. And then level 3 hypoglycemia occurs whenever there's a severe event in which the patient becomes altered, or there's a lack of physical functioning and they require assistance from another person for recovery. So this can happen at home in the form of a caregiver or a loved one, or sometimes this happens when a patient is brought into the hospital system. The way that I like to teach as well as utilize hypoglycemia treatment is by the 15 rule. And this is when we give 15 grams of fast-acting carbohydrates whenever a patient's blood glucose is less than 70 milligrams per deciliter. We'll instruct them to recheck their blood glucose in 15 minutes. And if it is not greater than 70 milligrams per deciliter, we'll repeat that 15-gram dose. So there's 3 15s within that. You can instruct your patients to give up to 30 grams of fast-acting carbohydrates, however. Glucose tabs or gel is preferred, and this is just because it's going to be fast-acting and it's in the form that the body can use. It is important to note that a glucose tab doesn't contain that 15-gram carbohydrates. That would just be too easy if it did. So you will need to instruct your patient to take at least 3 tablets in order to contain the 15 grams of carbohydrates to treat, because one tablet only has 4 to 5 grams of carbohydrates. If they don't have pure glucose on their person, they can use 4 ounces of orange juice, 6 ounces of cola, making sure that it's not diet, as this will not provide the same benefit, or 5 to 6 lifesaver candies. This hypoglycemia acute treatment should be followed with a complex carbohydrate within 1 hour. So if it's not, lunchtime yet, they would need a snack in order to hold them over until lunch. And then we utilize glucagon for those that are unable or unwilling to consume any sorts of treatment for their hypoglycemia by mouth. And the dose for this is 1 milligram subcutaneous, intramuscular, or intravenous. And then finally, we'll round out by talking about the hyperglycemic emergencies, which in the hospital system is something that I see quite often, and maybe one of my favorite parts of diabetes management. So our hyperglycemic emergencies are diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic state, or HHS. Often these patients will present with polyuria, polydipsia, polyphagia, possibly some quick weight loss, dehydration, especially with hyperosmolar hyperglycemic state, and then potentially fruity or ketotic breath for our DKA patients. When they present in this way, we'll often grab a set of labs which will point us towards the direction of DKA and or HHS. So for the glucose value, we do anticipate these to be elevated in both disease states. However, patients with HHS will be more elevated, so greater than 600 milligrams per deciliter compared to patients with DKA where they may be floating around 300. The last part of DKA is acidosis, so we do expect a lower arterial pH in our DKA patients, so anywhere below 7.3, while HHS patients will have a pH of greater than 7.3. The serum bicarbonate will also be lower in DKA patients, so anywhere less than 18 or low, and HHS should be relatively normal. Urine ketones and serum ketones are like our defining diagnosis of DKA, is that presence of ketones. So those will be positive, and HHS, they should not be present, or if they are, in very small quantities. In contrary, the serum osmolality is one of the defining lab values for HHS, so you'll see greater than 320 milliosmoles per kilogram, where this can be rather variable in DKA. DKA is one of our anion gap metabolic acidosis diagnoses, so we will anticipate that they may have an elevated anion gap, especially with severe cases of greater than 12. HHS, we don't necessarily anticipate this, so it could be variable. Mental status can be very severely impaired in HHS, while in DKA, this can be a range from alert and drowsy to a stupor or coma in our more severe patient population. Our treatment goals for these patients is, of course, to correct the dehydration, hyperglycemia, and electrolyte imbalances, as well as correcting the underlying cause. So the two items that are underlined are our most common causes within our guidance documents, but certainly within my clinical practice as well. I believe that it is pretty accurate. The first is discontinuing or inadequate insulin therapy. So this can happen for a multitude of reasons. Possibly the patient was taking their insulin and then they couldn't afford it due to loss of insurance coverage, or possibly a problem with the pharmacy. Maybe their insulin pump malfunctioned, or they weren't feeling so great. Maybe they were like a little bit nauseous for whatever reason, so they gave themselves less insulin or no insulin for particular coverage in order to avoid hypoglycemia, but they didn't correct enough, which allowed them to go into a hyperglycemic emergency. Our second most common is infection, so this can be anything from a simple UTI to more severe infections. Pancreatitis can cause our hyperglycemic emergencies. Dehydration can also cause these, especially HHS. And then because I'm a pharmacist, I'd be remiss not to include the drugs that can affect glucose levels. So the ones that I see most common in the hospital system by and far is corticosteroids. However, thiazide diuretics can increase glucose levels, as well as our atypical antipsychotics. Our treatment principles include fluids, insulin, potassium, bicarbonate, and phosphate, and this is the same for DKA and HHS. Our fluids will typically grab 0.9% or normal sodium chloride, and we'll start this at 1 to 1.5 liters per hour during the first hour. After the first hour, we will change our fluids based on the serum sodium. So if the serum sodium is low at that time, we'll continue the normal saline or 0.9% sodium chloride. However, if it's higher or normal, we may decrease the sodium chloride content and use half normal saline or 0.45% sodium chloride. We will decrease the rate to 250 to 500 milliliters per hour whenever we believe that dehydration is corrected, which will often be determined through the physical examination. And then we will add dextrose in the form of D5W to our fluids whenever the glucose drops below 200 milligrams per deciliter or less in DKA, or 300 milligrams per deciliter or less with HHS in order to prevent any hypoglycemia. And this will often be added to our half normal saline. Our backbone or our mainstay of DKA and HHS treatment is our insulin therapy. So typically this will be a continuous intravenous infusion. This is preferred for the short half-life and easy titration schedule. It can be started at 2 different doses. That's pretty well developed within the literature. So you can start at 0.14 units per kilogram per hour and just use the drip, or you can give a 0.1 units per kilogram bolus followed by 0.1 units per kilogram per hour insulin drip. You will then titrate, or the nurses likely will titrate the insulin drip per hospital protocol. Again, whenever we reach a glucose value of 200 milligrams per deciliter or less for DKA, or a glucose of 300 milligrams per deciliter or less for HHS, we will reduce the rate to 0.02 to 0.05 units per kilogram per hour in order to prevent hypoglycemia. And this is often when we also add in our D5W with our fluids. When using an insulin drip, hourly blood glucose checks are required by many hospital protocols, and certainly if it's not required, we will be wanting to monitor the blood glucose rather frequently in order to appropriately titrate the drip. Potassium is also a consideration, as insulin therapy, correction of acidosis, and volume expansion will decrease serum potassium concentrations. We will actually even delay our insulin drip therapy until the potassium is greater than 3.3 milliequivalents per liter to prevent hypokalemia and any arrhythmias that may result because of that. Once insulin is started, we'll add potassium to the fluids when the potassium is less than 5 milliequivalents per liter. So this can be added directly into the fluid bag and at 20 to 30 milliequivalents per liter of fluid, or this may be given outside of the bag as an IV piggyback. Bicarbonate is another electrolyte which we consider in the treatment of DKA and HHS. However, the replacement is rather controversial, as studies fail to show beneficial or deleterious changes in morbidity and mortality when we use bicarbonate to correct acidosis in DKA. And especially in children, repletion can be harmful. However, the guidance document does state to consider adding 100 millimoles or 2 ampules when the pH is less than 6.9, which is pretty acidotic. Phosphate is a third electrolyte that we consider. This concentration also decreases with insulin therapy. However, no studies show benefit with phosphate repletion in DKA or HHS. When the phosphate is less than 1 millimole per kilogram of body weight, you can consider adding 20 to 30 milliequivalents of potassium phosphate to fluids rather than a different potassium product. And then we can't leave these patients on the insulin drip forever, so we do need to realize how to appropriately transition from intravenous to subcutaneous insulin. We do this whenever the resolution of DKA occurs for our patients with DKA. So that's a blood glucose of less than 200 milligrams per deciliter and 2 of a bicarbonate of at least 15 milliequivalents, a venous pH of greater than 7.3, and an anion gap of 12 or less. The criteria for resolution of HHS is possibly a little bit simpler. So that's normal osmolality and normal mental status or baseline mental status. But another thing that I want to point out that I think is important and not necessarily in the criteria is that you do want to make sure that your patient is tolerating meals. If your patient isn't necessarily eating and then you give them a long-acting insulin injection, this could possibly cause them to be hypoglycemic. When you do decide to transition from IV to sub-Q insulin, you will continue the insulin intravenous infusion for 2 hours after the first subcutaneous injection, and that just allows um, the insulin to still be active within the system whenever the sub-Q injection is being absorbed by the body, because we know it might take that long to have an effect. The dose can be determined in 3 different ways. Sometimes it's appropriate to just start their prior to admission insulin. So for patients that were controlled prior on that therapy and potentially they stopped taking their insulin for whatever reason and that issue has been resolved, we can start the prior to admission insulin in order to adequately control them. The weight-based dosing scheme that's recommended for these patients is 0.5 to 0.8 units per kilogram per day. And that will be divided by 50% basal and 50% bolus insulin, like in our type 1 diabetic patients. You can also calculate the 24-hour insulin requirements based on the insulin drip rate. How I do this instead of calculating out all 24 hours, because it can be, one, very variable, especially if your patient was in pretty severe DKA or HHS during some of that time. But two, it's a little bit simpler and less tedious to just look back at the 6 hours. So I look back at the last 6 hours where they should be on a relatively stable rate, and I calculate how much insulin that they received in those last 6 hours, and then I will multiply that by 4 to get 24 total hours for their total daily insulin dose that they required within the last 24 hours. In order to be more conservative, I often multiply that by 0.8 or just take 80% of the dose and then split it into basal and bolus dosing. This is a graphic that is provided within the DKA and HHS Standards of Care document. So everything that we talked about previously is on this picture, but this is just, a one-stop shop to look at in order to see the treatment for our hyperglycemic emergencies. That concludes our lecture today. So some things that I hope that you can take away from this lecture is that we target an A1C of less than 7% in most individuals with diabetes. However, you can individualize these A1C goals. Insulin is the mainstay of therapy for our type 1 diabetics. Metformin and lifestyle modification is first line for most type 2 diabetics. And then we can select other type 2 diabetic treatments based on patient-specific factors. And the factors that we talked about today were heart failure, ASCVD risk, chronic kidney disease, cost, hypoglycemia risk, and weight gain avoidance. We also need to consider differences in management in pregnant, geriatric, and admitted patient populations. And then finally, each patient should receive counseling on hypoglycemia management at every visit for their diabetes. That is the end of my lecture. If you have any questions, I know I couldn't be there in person, but please feel free to reach out to me by my email. I provided that on this slide, and I should be able to respond to you at the earliest possible time that I can. Thank you, and I will be talking to you again for 2 more lectures.